Okay, now let's talk about the cerebral cortex. Now, this is the part of the brain that really separates us from the other animals. It's the part of the brain that makes us who we are. It's where the thinking, the planning, the judgment, and all of those quote-unquote executive functions happen. So thinking about the cerebral cortex, it can be divided into four lobes. You have the frontal lobe, temporal lobe, parietal lobe, and the occipital lobe. And generally speaking, these all have different functions. For example, in the frontal lobe, you'll find the precentral gyrus, which is where the primary motor cortex is, while in the parietal lobe, you have the postcentral gyrus, which is where the primary sensory cortex is. The temporal lobe is important for hearing, among other things that we'll talk about, and then the occipital cortex is known for its role in vision. The dominant hemisphere, which is usually the left hemisphere, contains Broca's area, which is an area that's known for producing speech. It also contains Wernicke's area, which is used for comprehension of speech. Broca and Wernicke's area communicate to each other via the arcuate fasciculus. Now, lesions in the arcuate fasciculus can present with problems repeating sentences, but we'll talk about this in more detail a little bit later. Something I want to briefly mention before we move on is the difference between the left and right hemisphere of the cortex. Now, this is certainly a simplification and is largely based on data from right-handed individuals, but generally speaking, one can think of the left hemisphere as controlling things like speech, logical reasoning, math, science, whereas the right hemisphere would be known for controlling things like visuospatial functions, art, so music, drawing, things like imagination. So this is something to think about when you're reading a vignette where the patient has some cognitive deficit. Aphasia is the inability to speak due to a cortical lesion and must be distinguished from dysarthria, which is a problem with the mechanical production of speech by the tongue and mouth. So what is one test that we can use to distinguish dysarthrias from aphasias? So a good test is to have the patient communicate by writing. Written language is preserved in dysarthrias, whereas in aphasias, it is not preserved. We'll talk about this a little bit more in a while, but first let's briefly discuss the major types of aphasias. Broca's aphasia is also called a non-fluent aphasia. These people can understand perfectly, but they cannot express themselves, sort of what I was just doing. So this can be a very frustrating type of aphasia to have. Broca's aphasia is usually caused by an infarct in the superior division of the middle cerebral artery of the dominant hemisphere. Wernicke's aphasia is also called a fluent aphasia. These people can sometimes we have to go to the palace, but the king, we had to record lectures, but then sometimes my phone was ringing, so I have to stop. But then I want to learn more medicine because step 3 for residency, but I want to go. So these people can produce a lot of words, but they will not be able to string them together into meaningful sentences. And they don't actually understand that they're not making sense, so this is usually not frustrating. Wernicke's aphasia is caused by infarcts in the inferior division of the MCA in the dominant hemisphere. Now, global aphasias occur when both Broca's and Wernicke's areas are affected, as in a large MCA infarct, which would affect both the superior as well as the inferior divisions. Conduction aphasias refer to patients with normal fluency and comprehension, but they have impaired repetition. This type of aphasia is caused by any lesion that damages the arcuate fasciculus. This is the pathway that connects Wernicke's to Broca's. So if you think of Wernicke's as understanding sort of what the words the person said were, when you want to repeat them, you have to sort of somehow send that information to Broca's to then, have the motor output of speech at some point. So if you damage this pathway, then you aren't able to take the words that you heard and send them to the region that can then produce those same words. Transcortical aphasias keep the arcuate fasciculus intact, and as a result, repetition remains intact. Transcortical motor aphasias are non-fluent aphasias, while transcortical sensory aphasias present with fluent speech. This makes sense as motor areas are necessary for speech production and as a result, fluency of speech. Transcortical sensory aphasias present with poor comprehension as sensory areas are necessary for comprehension of speech. However, as I mentioned, you will have fluent speech. You should certainly be familiar with aphasias. Luckily, as with a lot of the information in this chapter, there's an intuitive way to approach this. If you think of where Broca's region is, you see that it is in the frontal lobe and can be thought of as a motor area for speech. So it makes sense that there comprehension is intact, but that you have trouble producing the words. This problem in production is equal whether the form of communication is written or spoken. As we mentioned before, this is a major way to distinguish aphasias from dysarthrias. In contrast, Wernicke's area is in the temporal lobe, in a region that is responsible for processing and making sense of sensory information. Thus, the problem here is not production of words, rather it seems that the meaning of language is lacking. Now, lesions can theoretically occur anywhere in the brain. The size and site of the lesion will determine the types of symptoms one will see. For step 1, there are a number of brain lesions you are expected to know, so you should make some time to review the chart in your book. As I've mentioned before, the main thing to remember when going through lesion syndromes are what the area that is lesioned is normally responsible for. From there, it should be pretty intuitive to figure out what the symptoms of that lesion would be. So let's start with a pretty famous lesion. This is Kluver-Bucy syndrome, and this occurs when the amygdala is damaged bilaterally, and this results in hyperorality, hypersexuality, and disinhibited behavior. Think of this as the Friday night fraternity party on your college campus. One gets these symptoms because the amygdala is important for generating anxiety and fear, which is important for inhibiting behavior. Think about when you've wanted to do something that you know is inappropriate. That feeling of hesitation that you get before you do it or while you're deciding whether or not you want to do it, that is being generated by the amygdala, among other things. And so you could imagine if your amygdala is not there, you don't have that feeling of hesitation, you might end up doing that thing that could be pretty embarrassing. Hence the Friday night party that your fraternity throws analogy that I brought up. If there is damage to the non-dominant parietal temporal lobe, you end up with something called a spatial neglect syndrome. Now this is really a fascinating condition. Imagine an existence where although you're getting primary visual information and other sorts of sensory information from everywhere, you only can pay attention to half of that information. So one way you might see this in the clinic is that a patient has no understanding that a contralateral side of their world exists. So one sign that you might be dealing with this syndrome is that a patient, when asked to draw a clock, will draw something that looks like this. Right, where they ignore the fact that there's supposed to be another side of the clock. Another kind of cool manifestation of this can actually happen in dogs where, you give them a bowl of food and they will only eat, half of the bowl of food and the other half will remain sort of untouched. Now, if damage occurs in the dominant parietal temporal cortex as opposed to the non-dominant, patients present with something known as Gerstmann syndrome. This consists of a deficiency in writing and understanding math, the inability to recognize fingers as well as left-right disorientation. The reticular activating system is a set of nuclei in the midbrain that releases both cholinergic as well as noradrenergic neurotransmitters. This system regulates arousal and wakefulness, so it makes sense that a lesion in this area would lead to reduced arousal, and it can even go as far as putting the patient into a coma. The Wernicke-Korsakoff syndrome involves bilateral lesions of the mammillary bodies. This is commonly seen in patients who abuse alcohol. The Wernicke aspect consists of confusion, ophthalmoplegia, and ataxia. Now that's a classic triad that you should definitely be aware of: confusion, ophthalmoplegia, and ataxia. From there, it can then progress to Korsakoff. And from there, you get memory loss, confabulation, and personality changes. Now, if you think back to your biochemistry, you remember that this syndrome occurs due to lack of a particular vitamin. Do you remember which vitamin this is? That would be thiamine, or a B1 deficiency. This is the main cause of Wernicke-Korsakoff. Thiamine deficiency is typically seen in chronic alcoholics, and this is why there's this correlation between alcohol and Wernicke-Korsakoff. We talked a bit about damage to the basal ganglia and cerebellum. Damage to the subthalamic nucleus, shown here, is responsible for causing contralateral hemibolismus. As we've discussed before, this is a very classic brain lesion. The hippocampus, as you know, is critical for memory formation. So, lesions to the hippocampus cause anterograde amnesia and inability to make new memories. Something important to remember about the hippocampus is that it is very sensitive to anoxic injury. So, if a patient has been without blood flow for a while or is unable to breathe for some time and you are asked about a brain region that might be damaged, the hippocampus should definitely be on the top of your list. The next two lesions deal with the visual system. Damage to the paramedian pontine reticular formation, or PPRF, will end up causing the eyes to look away from the side of the lesion. If, on the other hand, you damage the frontal eye fields, which is by the premotor cortex, you get the opposite result and the eyes would look toward the lesion. Again, you should really take the time to know what the different brain regions do. This initial effort will make it very easy to figure out what the different symptoms are telling you about which brain regions are likely involved. Alright, it's time for a flash quiz. What are Broca and Wernicke's area? These are both areas in the dominant hemisphere, which is usually the left hemisphere, and they are involved in communication. Broca's area is involved in speech production, and Wernicke's area is involved in comprehension of speech. And again, we'll talk about these a little bit later.